Hello, I'm Donal Macaulay and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Ireland and I'm talking to Áine Carroll. Now, what I really like is Áine's slightly oblique approach to traditional medicine. Áine, tell me a little bit about your career and your current job.
So my name is Aine Carroll. I am by background a consultant in neurological rehabilitation medicine at the National Rehabilitation Hospital in Dublin. But I also wear a number of other hats. So I am Professor of Healthcare Integration and Improvement at University College Dublin, and I'm also current chair of the International Foundation for Integrated Care. And I'm co-director for the IFIC Ireland hub. So I have a lot of different interests. There's a thread of integration that runs through them all, but I'm also really interested, especially from not just an academic point of view, but the practical application of knowledge to the day-to-day work that we do in health and care. So I'm really interested in learning systems and healthcare being viewed as a complex adaptive system.
So before we get on to changing the systems, tell me a little bit about integrated care and what it really means.
So just before I got very involved in IFIC, I was National Director of Clinical Strategy and Programmes within our health system, which is the Health Service Executive. So at that time, I would have been responsible for 35 clinical programmes. And so each of those programmes was really important, really worthwhile, really taking an evidence-informed approach to how we were thinking about models of care. But each organ had its own model of care. And one of the things that I and colleagues came to realise is that actually we need to join things up. Our patients don't present as a heart or a brain or a kidney. We are wonderful systems of organs. And how we are currently designing and providing our healthcare systems isn't working for the whole of human beings. So we recognised that we needed to start to do things differently, and that really brought me into the whole area of integrated care. So I could give you, even when you look at the literature in integrated care, it is the most heterogeneous, fuzzy thing imaginable in the literature. So IFIC, we're not very bound by any set definition because it really does depend on your context, but having a shared understanding about what that means. And I suppose in its purest form, what that means is person-centered, coordinated, continuous care that deals with the issues that matter to the individuals and their family.
An aspect of that is the integration with primary care, and primary care doctors would say that they really focus on personalized, coordinated care. How does that fit with your model of integrated care?
In the work that I've been doing, Donal, when you ask individual clinicians about how they provide care, the answer I get all the time is, sure, we're doing that anyway. And unfortunately, I wish that were true, but when we look at the evidence and when we study how we're currently providing our services, we're not. We are not. And I think it's really important that we acknowledge that. Now, there are some pockets of really good care. And immediately when you talk about primary care, I immediately think about Ghent and the work of Professor Jan de Manserman. The man is a legend. I'm a complete Jan fan. And if everyone in the world could receive primary care the way Jan de Manserman and his team provide it, our patients would be happier, families would be happier, we as clinicians would be happier. So there are lots of really good examples of how to do this really well. But unfortunately, most of the time when we look at the evidence, it is disintegrated care, it is fragmented, and it's certainly not organised around the needs of the people we purport to serve.
So that brings us back to one of your other interests, and that is system change. So how do we make that happen?
That's the $24,000 question. So the IFIC 9 pillars, I think, are a very useful way of thinking about the areas that we need to consider when we're thinking about integrated care. And I'm going to concentrate just on integrated care and maybe then briefly touch on systems, because it is an integrated care happens in systems, happens in human systems, it happens for human beings who are human systems. So the 9 pillars are a very useful, you can call it a framework or a tool, whatever you want. I'm not precious. These are just the things that we need to think about. So we've already touched on the need for a shared vision and purpose around what it is that we're doing when we're thinking about any change initiative. And then we need to think about that happens within a population health context and also in unique contexts. And we can have a whole discussion on what context means, but everyone has kind of an innate understanding of context. So it is really important that we think about context. Then the next area that's really important are people as partners in their care, and meaning that, and rather than this is what we're going to do to you, or here's a thing that we're going to plan to do, I mean a real partnership, co-production, so true partnership. Then resilient communities, and I know resilient is a real buzzword at the moment, but resilience is really important, and especially within the context of our communities. And looking at the roles of those third sector organisations and all those community-based assets that we have that we are not utilising to the full potential to support our neighbours and our people in our neighbourhoods. Then, of course, our workforce. Have we got a workforce that's designed for modern healthcare? No, it's not. We're still being educated in disciplinary silos. We really need to bring those worlds together, because at the moment we magically expect people to come out of their undergraduate career and bing, magically work in teams. We need to do a lot more about interdisciplinary education at an undergraduate and a postgraduate level. Then, of course, system-wide governance and leadership. We talk about leadership a huge amount without really clearly articulating what that means. And I look at leadership, it's a group endeavour. It's a group endeavour of people that are working to work together towards a common goal. That's leadership, not this notion of traits and born leaders and that nonsense that needs to be consigned to the pages of history. The importance of digital. So in the South, we are really stymied by the lack of the ability of our information systems to connect together, or even to have information systems in the community, for example. So GPs are really good. Over 90% have got one healthcare solution that they use that doesn't talk to anyone else. So how can we actually use digital to help that? It's like the glue and the grease of integrated care, and indeed any other type of care. And then payment systems. So we currently fund our care, our health and care in silos. So what more can we do better together if we do not just align, but truly integrate our payment systems? And then the last is, of course, learning system, transparency of results. So sharing knowledge, sharing information in real time about, so how's it going? How is it for you as a utilizer of our healthcare services? How is it for me as a provider of those services? How is it going from a KPI point of view? How is it going from a carer or family member point of view? And there are tools and there are approaches that you can take to have access to that type of information in real time. There are just very few organisations and entities that are brave enough to be willing to be curious enough about that type of data in real time. And to me, that could be truly transformative if we are courageous enough to take that step. So how do we do that? And we're also completely born and raised in this notion of linearity and positivity. So A plus B equals C. Whereas real life is messy, it is unpredictable. And we need to settle into that uncertainty and unpredictability if we are really, truly to get further, faster. And if we do that, and we're curious and we're getting all sorts of data to inform the decisions that we're making, then I believe that will really transform how not we just think about health and care, but actually how we really, truly really embrace all of our citizens and residents in our different countries and make the very most out of the resources that we have and treat all of our assets as really precious and bring those things together. And I think if we do that, and if we are willing to develop those types of relationships and trust people, then something really magical could happen. And where you have those ingredients and where you have that curiosity and that openness and that understanding of the complexity of health and care systems, then that's where you see that those magic results emerging from people who are curious and open and willing to do things differently.
Well, I love this idea of this circular orbit of integrated care. And on one side, slightly semi-detached is primary care, but also on the other side, drawing on that is government policy.
Yeah.
Now, I'm interested in how government policy is going to affect this. And I know you have particular interest because you have practically written about government policy on road safety, for example, and how it affected your own work.
In countries where they have had policy around integrated care, you can actually move things further, faster, because you can say, here is the policy, this is government policy. And interestingly, I was just talking to a colleague from Lithuania, and their ministry has now got an integrated care policy, and they see that as a huge lever for change. But having said that, in Ireland, we started doing the integrated care programmes without the policy. The policy followed, Sláinte Care followed the work that we had already started in the integrated care programmes. But, you know, is that a good thing? Is it good that we've got a cross-party agreement about the need to move things into the community and to become more person-centred? Of course, that's a good thing. So politics can be a barrier, but it can also be a very key enabler. And then just to go to the road safety, that was a huge game changer, a massive game changer from a road safety point of view. Now, there are issues with the numbers at the moment there, we can't deny that, but that takes me nicely back to complex adaptive systems. So yes, that was fantastic, numbers came down. Then you need to adapt to the changing circumstances and think about, okay, what do we do next? How do we adapt to these changing circumstances? What is it that we perhaps need to stop doing? What do we need to start doing that we haven't thought about? And the technology, in any healthcare system, including road safety, the technology is mind-blowing. It's absolutely extraordinary about what can be done to vehicles to make them much, much safer and to help support you as a decision maker driver about the things that you do. So the technology is, we need to work with that technology to see how that works. But the other thing from a road safety point of view is a 5-point belt. I think everybody should have a 5-point belt.
Now let me bring you back to the integrated care, because you described a beautifully organized structure and organization for integrated care. But you know what I'm going to say now, because you've been interested in complexity theory, which really means we have no control over this whatsoever.
So I wouldn't quite say with no control. So the future is unpredictable. So complexity theory has, especially not just complexity theory, complex adaptive systems theory, recognizes certain principles of certain systems. So in its simplest form, you can divide systems into complex physical systems, complex adaptive systems. Complex physical systems respond to the usual laws of physics. Complex adaptive systems absolutely don't. So complex adaptive systems are more organic, natural systems, like human systems. So I like to describe them. Rika Preisner and colleagues in Stellenbosch University really nicely brought all the key thinkers from a complexity point of view together, and she pulled out certain principles that I tried to add to in a literature review that I did, but I couldn't, because actually she'd nailed it. So she describes that there are 6 principles, 3 structural, 3 processual. So the 3 structural are that we're constituted relationally. So like human beings, we are relational. No man is an island, as the saying goes. We work in human systems, we're in families, we're in work groups. Then that they are constituted contextually. So context is really important. Your context is unique, my context is unique, and our shared context can be quite similar, but it has got its own differences. And then you've got the structural and the processual. So they're adaptive, they're dynamic, and when human beings interact with each other, something very special that can come out, can emerge from those interactions that are, that's not linear, it's non-linear, so it can be quite dramatic. And I think how we responded to COVID is a really nice example of that non-linear response. So the healthcare system and human systems comply with those principles. And that, as you were saying, it does mean that the future is unpredictable. However, what we can do is to be curious at this moment in time about what's happening at this moment in time. And we can make sure that we are receiving data in all its forms to make the best decisions that we can. And if we start to do that, then we will start doing very different things. But we're still really attached to the notion that there's a quick fix, there's a simple solution, when there is not a simple solution to a complex problem. We keep looking for, I don't know, a consultancy firm or some guru that's going to give us this silver bullet. There isn't a silver bullet. We need to embrace that uncertainty and that complexity and have that curiosity and that learning, thinking about what is the data that we need, how are we going to collect it? But key, and this is the big gap, is it's not just about collecting it, it's responding to it. What actions are we going to take? And in my experience of healthcare systems around the globe, that's where we get stuck.
Can I bring you onto another area? And this is our final question. It's really just to address very briefly another area of interest, and that is of women in medicine and the gender change in medicine, which again requires systems adaptation.
It certainly does. So I am secretary and vice chair of the Women in Medicine group, which is led by my fabulous colleague, Sarah Fitzgibbon. So that was founded to try to address some of the issues that we had identified. So back when we started, I remember at the first women conference we had, I looked at the data. So pulled data from a number of different data sources, and I looked at the transition of women in medicine from undergraduate to postgraduate. So you're absolutely right. We have more women than men studying medicine at the undergraduate level. But at a couple of years postgraduate, that's when you really start to see the changes in terms of the choices that women make and also the opportunities that they are afforded. And why is that? Because women are not encouraged in certain disciplines. So the College of Surgeons in Ireland, for example, are doing an awful lot of work to try and address the gender issues in surgery. But there's lots of other areas that need attention. So as you career progression, women drop out, so that you end up with a male top-heavy situation, especially at consultant level. It's more balanced in general practice, which I think is really to the good of general practice. So big thumbs up for general practice. But we have a job of work to do in hospital medicine specialties. And we cannot deny the fact that there is accumulating evidence that female surgeons' outcomes are better than males. Now, I know that there are lots of hot debates about the data, but I think there is enough accumulating data that we really need to be having grown-up conversations about why that is. And rather than fighting about it, about going, well, that's really interesting, why is that? And really trying to understand why that is the case. Now, initial evidence would say that women are more likely to comply with guidelines and with checklists and with evidence-informed practice than males are. So that's an interesting finding. So let's explore that in a bit more detail and look at then how can we use that information to really support all our trainees, not just at postgraduate level, but also at undergraduate level. Let's talk about this stuff. Let's really be honest about what it is that we're doing. And let's also be honest about how decisions are taken about career opportunities. Let's open our medical careers to everybody, not just from a gender point of view, but really embracing diversity in all its rich colours. because we represent, or we look after, a population that is hugely diverse and wonderful, a wonderful rich tapestry of humanity. Medicine should reflect that as well, and we should make it as rich and as colourful as the environment and the citizens and residents that we serve.
Áine, it's always inspiring to hear you talk. Thank you
You're
very
so
much
kind.
indeed. It's an absolute pleasure to talk to you today.
And likewise, thank you for asking me.